Hello, I'm Judi Kidger, a Senior Lecturer at Bristol University, and I'm going to present our study, which is an evaluation of an adult talking therapies service that links into community services. And our study team is made up of researchers from Bristol University, the University of Sheffield, and South Gloucestershire Public Health Team. So the background to the study. Improving access to talking therapies, which is IAPT in its shortened form, was introduced in 2008 as a national strategy to support population mental health. And there's some evidence that it works to improve mental health at the individual level in the short term. But questions have been raised about how effective it is to create better mental health across a population. And one of the criticisms is that it doesn't really address the wider determinants or the wider causes of poor mental health. So things like poor housing, isolation, concerns with debt, none of those are really addressed through the traditional service. So a new IAPT service has been developed across Bristol, North Somerset and South Gloucestershire, which will create stronger links to services that are provided by community partners which address those wider determinants. So the new service, or the intervention as we're calling it in the study, works in the following way. So somebody enters the service either through self-referral or referral from another party. They might receive the traditional IAPT service where they get the talking therapy, but they might receive that traditional service and also be given additional support. And that additional support would involve either having a wellbeing navigator or a healthy living, healthy minds worker. And that person would link the person that's using the IAPT service into these wider community supports. And the third possibility is a person referred into the service or that refers themselves to the service may just get that additional support that deals with their wider issues. So our evaluation. We're looking at the following research questions. So we're asking, does the enhanced IAPT service that blends high quality clinical support with a clear referral pathway to wider support, does that deliver better mental health outcomes than clinical support alone? We're also asking, is that enhanced model cost effective in terms of seeing improvements in outcomes? Our third question is about the process by which the enhanced service is delivered. So that includes how are people selected to get the additional support, and also what are the barriers and facilitators to the process working well. And our fourth question is, which populations benefit the most from the IAPT, the new IAPT model, and what impact does that new model have on health inequalities? So we're addressing our first question about whether we see better outcomes in the new service by looking at the routine data which are routinely collected across all IAPT services, and those routine data look at depression, anxiety and functioning. We're going to look at that in the intervention group. So by intervention group, we're looking at everybody who accesses the new service between March and August of this year, and we're going to compare them to two other groups. So the first group we're looking at is a historical comparison. So we're going to look at everybody who accessed the old service in the same geographical area between March and August 2018. We're going that far back to make sure we don't capture a time point where the old service was finishing and running down. We've then got a second comparison group, which is going to be a different geographical area with a more standard IAPT service. And we're going to, again, look at their outcomes between March and August 2021. The reason we've got two comparisons is because with the pandemic happening at the moment, it's possible that a historical comparison isn't really comparing like with like. There may be new challenges, new mental health problems, which the new service are dealing with, which didn't exist in the past. Our second question about whether the new service is cost effective will be done in two ways. So we'll look at information from the study to estimate costs and effects over the study period. And we'll also do some modelling, which is where we'll synthesise other evidence from a range of sources to estimate what the costs and effects would be over a longer period of time. Our third question about the process we're going to look at qualitatively through focus group and interview data. So we're going to speak to a whole range of people who are stakeholders in connection to the new service. We're going to include service users, service managers, therapists, wellbeing navigators, healthy living, healthy minds. We're also going to speak to bid developers to see what their vision was for the new service and whether they think that has been put into practice. We're going to look at people who refer into the service and also the community providers who we're hoping the new service will link service users into. And our last question we're going to look at with the routine quantitative data. So we're going to be able to look at which particular groups seem to be referred into the newer aspects of the service. We're also going to look at it qualitatively by making sure that we include in our sample people from groups who we know are at risk of poorer mental health outcomes. So just to end with our timeline, everything is really beginning from now. The new service is just getting going and we are hoping that we're about to receive ethical approval to go ahead. The outcomes from the study will be available early next year. And just a note on public and patient consultation. So we're working closely with the Independent Mental Health Network to ensure that we're regularly consulting with groups of the public about our approach to the study and also in time about our findings and the implications. Many thanks for listening.